Got a secret, can you keep it? Swear this one you'll save. Better lock it in your pocket, taking this one to the grave. If I show you, then I know you won't tell what I said. 'Cause two can keep a secret if one of them is dead.
Hi, Aria.
Hey Mona, how was your first day back after vacay?
Oh, it was alright. You have 411B?
I do. Let's get a report on him.
Alright, he's a 44-year-old male, came to the ER 4 days ago with abdominal pain. It wouldn't stop and was made worse when he was, when he would eat, move around. Dr. Hastings on his case, he found his gallbladder full of stones, so he did a total traditional cholecystectomy. He's 3 days post-op, no allergies, no past medical history other than a fracture of his right arm when he was 8 years old. He's on room air, he gets up with a little bit of assistance, regular diet, has a menu by the bedside. He has a 28-gauge IV in his right AC hooked up to 0.9% normal saline running at 50. T-tube in place on the right upper abdomen. It's draining about 10 milliliters an hour of about yellow bile, same type drainage, no blood or anything. He's alert and oriented times 4. All his vitals have been normal, just a slight temp increase around 5 that went up to 100.2. Bowel sounds present, just a little bit of tenderness around the incision that he complains of. No real complaints. His labs were drawn, just might want to check back, no results yet. PT was in around noon to get him up and moving. He tolerated that very well. His wife, Emily's at the bedside. She's very involved in his care. And Hannah will be his aide tonight. She just started her vitals.
All right, sounds good.
Okay.
The gallbladder is a pear-shaped organ located on the upper right side of the abdomen, just below the liver. Bile is released from the liver, but is stored in the gallbladder. Bile helps with digestion by breaking down fats into fatty acids, where it is then released into the body. Cholecystectomy is the surgical removal of the gallbladder. There are 2 surgical methods of removal. The first one is laparoscopic, and the second one is traditional, also called open. The laparoscopic way of removing the gallbladder is minimally invasive. 4 small incisions are made into the abdomen, and a tiny tube with a camera is inserted through one of the incisions. This helps the surgeon guide the tools necessary to remove the gallbladder. This surgery is most often performed as an outpatient procedure. During the traditional way of removing the gallbladder, the surgeon makes a 4 to 6 inch incision in the upper right section of the abdomen. The muscles and tissues are pulled back, revealing the organs, such as the liver and the gallbladder. The surgeon removes the gallbladder and sutures up the incision. This is done as an inpatient procedure. Some reasons why a person might need their gallbladder removed are cholelithiasis, which is gallstones in the gallbladder, cholecystolithiasis, which is gallstones in the bile duct, cholecystitis, which is inflammation of the gallbladder, and pancreatitis, which is inflammation of the pancreas. The recovery period differs between laparoscopic and traditional. For laparoscopic, the patient usually goes home the same day of surgery. It also takes about 1 week to recover. With traditional, the patient spends about 2 to 3 days in the hospital and takes about 4 to 6 weeks to recover. What to watch for after surgery: bleeding, blood clots, bile leak, infection, heart problems, pancreatitis, and pneumonia.
Hi, Mr. DeLaurentis. My name's Hannah. I'm going to be the aide with you tonight. I'm going to grab your vitals, okay?
Okay.
Just put this under your tongue for me, please. Okay, thank you. Is there anything I can get for you right now?
I'm just having a whole bunch of pain right now.
Okay.
This just started about a half hour ago.
The nurses are getting a report right now, but I'll let them know about your discomfort.
Thank you.
You're welcome. Don't hesitate to press your call light if you need anything, okay?
Okay.
Hey, Aria. Hey, Hannah. How are you? I'm good. How are you doing? Good. I wanted to let you know, I was just in room 411B with Mr. De Laurentiis. He told me he's really uncomfortable and he's having a lot of pain. I took his vitals for you. His blood pressure was 142/82. His heart rate was 102. Respirations were 18. And his temperature was 102.5.
All right. Sounds like something is going on. I'm going to go in there and check it out.
Hi, Mr. De Laurentiis. This is Aria. She's your night nurse. She's going to be taking over for you.
Hi.
Hello, Mr. De Laurentiis. Hannah tells me you're in a little bit of pain right now.
Yeah, I just can't get comfortable, and I just am in a lot of pain.
Okay, would you mind if I did an assessment on you?
No, go ahead.
All right, so your blood pressure was a little bit elevated, which could be due to your pain. But what's concerning me now is your temperature is starting to rise. So I'm going to listen to your lungs, listen to your bowel sounds, and check you over.
Sounds good.
I see your normal salines running at 50. No complications with your IV site. Go ahead and take a deep breath once I place my stethoscope. Okay, now I'm just going to listen to your abdomen. I'm having a hard time hearing bowel sounds, so I'm going to listen to each quadrant for 5 minutes.
Okay.
Postoperative paralytic ileus is the hypomotility of the gastrointestinal tract with the absence of a bowel movement. Postoperative is the most frequent setting to develop an ileus. Immobility, pain, and discomfort are the most common risk factors in developing an ileus. Some signs and symptoms of a paralytic ileus are mild abdominal pain, bloating, nausea, vomiting, poor appetite. The patient may or may not be passing gas. Abdomen may be distended and tympanic, tender to touch, and absent or hypoactive bowel sounds. Treatment of a paralytic ileus most often resolves with supportive treatment, IV hydration, ambulation, and patients with nausea and vomiting may require a nasogastric tube. The patient's diet should be switched to NPO, and the general diet should not be resumed until bowel sounds are present and the patient has passed stool.
Mr. De Laurentiis, what would you rate your pain at right now from 0 to 10, with 10 being the worst?
I would say it's a good 9.
9, so you're in a lot of discomfort.
Yeah.
I'm just going to peek at your incision. I'm just going to lift your dressing a little bit.
Okay.
It seems to be red and tender.
Ow.
Does it hurt when I touch around
Yeah.
it? I'm just going to inspect your T-tube draining. So it seems to have a darkish hint, which it was draining a ferrous fluid. I'm just going to empty the drainage bag. 350 milliliters. So I'm going to go see what the doctor has ordered for your pain so we can make you a little bit more comfortable. And I'm also going to call the doctor and give her a little update on what's happening. Is there anything else I can do for you right now?
No, please just hurry.
Okay. All right. Let's see what Dr. Hastings has ordered for Mr. De Laurentiis. So he's got hydrocodone acetaminophen PO for a pain from 1 to 5. That's not what we want. Oh, here we go. Morphine IV, 10 milligrams every 4 hours for pain higher than 5. Mr. De Laurentiis, I brought you something for your pain. We're going to give you 10 milligrams of morphine IV, since you rated your pain at a 9. So I'm just going to go ahead and check your bracelet. Can you tell me your name and birth date?
Alan De Laurentiis, 3/31/1973.
Okay. So the protocol for this morphine IV push is pushing it over 4 minutes. So while I was at the computer, I looked at your labs that were drawn, and your white blood cells are a little bit elevated. So this could mean that you could have an infection starting or occurring in your body. So I'm going to wait to get a call back from Dr. Hastings, and I'll keep you updated if we hear anything.
Thank you.
Thank you. Yep.
Some signs and symptoms of a surgical infection are pus or drainage, a foul smell, fever of 101 or above, warmth around the incision site, redness, and tenderness to touch.
Hi, Dr. Hastings. I'm taking care of Alan De Laurentiis in room 411B.
Okay.
He is complaining of extreme discomfort and pain around his incisional site and T-tube. I took the dressing off, and the site appeared to be red and swollen, still some blood around the staples. When I touched the site, he screamed in pain. The tube is still draining, but has a green tint to it, which used to be a bile drainage. He also has no bowel sounds when I auscultated each quadrant for 5 minutes. He has stopped having bowel movements and also is not passing gas. His vitals were blood pressure 142/82, heart rate of 102, respiratory rate of 18, and temp of 102.5. His labs from this morning were normal, except his white blood cell count was 15.9. I administered morphine as ordered, and currently all that is running is 0.9% normal saline at 50 milliliters an hour.
Okay, awesome, thank you. We're going to go ahead and keep his pain under control with the morphine. I'm going to change his diet to NPO, except he can have sips with his meds, his PO meds, until his bowel sounds return. We're going to increase his normal saline to 125 milliliters per hour, and once he's more comfortable, we're going to have him ambulate more, and hopefully we can get these bowel sounds back. I'd like you to do a culture on the incision stat. I'll also put an order in for 600 milligrams of ampicillin to infuse over 1 hour. Once his culture comes back, I'll go ahead and change the order as needed. I'll go ahead in there with you and talk to them and take a look at the incision. I'm also going to write an order for acetaminophen at 325 milligrams PO as needed for his elevated temperature. Do you need anything else?
Nope. I'll go get the meds and get the culture.
Okay, thanks.
Hi, Mr. De Laurentiis. How are you doing with pain? What would you rate your pain now from a 0 to 10?
It's about a 3 right now, so it's pretty good.
3?
Yeah.
That's good. I'm glad you're feeling a little bit more comfortable. So I just talked to Dr. Hastings, and she ordered some new meds, and she also wanted me to get a culture and a dressing change.
Okay.
So I'm just going to do your culture first.
What's the culture for?
Basically, the culture is going to tell us if there's any infection in the incision, and if there is, it'll tell us, what antibiotics we need to treat it.
Oh, okay. Okay.
So I have Hannah here with me. She's going to be helping me. So first, I'm just going to take the old dressing off. It's a little red. Does it still hurt around it?
It's tender, yeah.
Okay. All right, I'm just going to swab your incision. And we'll send this down to the lab and I'll let you know the results once they come back with it. Okay. Hannah, could you hand me a 2x2, please?
Of course.
All right, and could you put some saline on it? I'm just going to dab your incision. Might feel a little cold. Could I have another 2x2? And this one's just to dry. Could I have a 4x4 gauze? No. And an ABD pad? Alright. Just going to tape your dressing, Mr. De Laurentiis. Thanks for your help, Hannah. Alright, so I'm just putting my initials and the date and time on this dressing so we know when it was changed and its next time to be changed.
What is a T-tube? A T-tube is a T-shaped tube. It is placed in the bile duct to drain bile while the duct is healing. It is usually left in place for about 10 days. A patient can go home with the tube in place and it will be attached to a drainage bag. Before it is removed, an x-ray is done to make sure no stones have developed in the duct.
So Dr. Hastings has also ordered some new medications. We're going to give you 1 gram of ampicillin. We're going to hang an IV piggyback. She's also made you NPO, which means you can't eat or drink anything. She did this because you had no bowel sounds and you weren't passing gas or stool. So she also wants us to get you up and walking so we can try and restore bowel sounds. And she also has ordered acetaminophen for your temperature that you were spiking. So I'm going to go ahead and hang your ampicillin. And this will run over 1 hour. Dr. Hastings also wanted us to change your normal saline rate to 125. So this will kick in as soon as this is done. Before I start it, I'm just going to recheck your... Can you tell me your name and birth date?
My name is Alan De Laurentiis, 3/31/1973.
Okay. Is there anything else I can get either of you?
No. Do you need anything?
No, I'm good, thank you.
Okay, hit your call light if you need anything at all.
Thank you.
All right, Mr. De Laurentiis, it looks like your antibiotic is all done running. How are you feeling?
I'm feeling okay.
Do you think you're able to get up and walk a little bit? Doesn't have to be far.
Yeah, I would like that.
All right. Hannah's just going to get another set of vitals before we get you up. You feeling okay?
Yeah, I'm feeling fine.
Hi, Mr. DeLaurentis. I'm
Hi.
Dr. Hastings. How are you feeling?
I'm feeling good.
I'm sorry about earlier when you weren't feeling so well. I'm hoping these antibiotics will make you feel a little bit better. I was glad to see you up and walking around the hall. That should help the movement in your stomach.
Yeah, it felt good to walk around a little bit.
Good. Okay, so I had the nurse Aria do a culture on your incision to figure out the source of the infection. I also had her start you on ampicillin, which is an antibiotic to help treat the infection. She also gave you acetaminophen, which is Tylenol, to help with the temperature you're running. I increased your IV intake because I switched you to NPO besides the small sips with your antibiotics. Your culture did come back, and it seems you have a staph infection in your incision. Since I know the source now, I'm going to have Aria switch the antibiotic to Ancef. Have you ever taken this before?
No, I never have.
This is a specific antibiotic that's going to help fight the infection. If the infection doesn't get any worse and you have a bowel movement, you can more than likely go home tomorrow.
Good.
Will he have to be on any medication at home?
Yeah, I'm going to write him a prescription for the antibiotic pill in pill form.
Okay.
So you won't have to worry. We're not going to send you home blind. We're going to go ahead and teach you all about it, make sure you understand, and we're going to schedule some follow-up treatments.
Okay, perfect.
Well, Aria hangs your new IV antibiotic. Do you mind if I take a quick listen?
Mm-mm.
Okay. Is it still tender at all?
Not as tender as it was.
Let's take a look. Let me put some gloves.
Mr. DeLaurentis, I have your Ancef. Can you tell me your first and last name and your date of birth?
Alan De Laurentiis, 3/31/1973.
Okay.
Okay. Hopefully that'll heal up nice, and we'll go ahead and get rid of that infection for you. Any tenderness, anything?
Mm-mm.
I'm going to go ahead and listen for some bowel sounds. Okay, it seems the walking has helped a little bit. We're still going to keep an eye on that to make sure everything checks out okay. If you have a bowel movement, you'll be able to go home tomorrow.
Thank you.
Okay.
Mr. DeLaurentis, how can I help you?
I just got up and went to the bathroom and I actually did poop.
Okay, I'll let Aria know. Mr. DeLaurentis, Hannah just told me you had a bowel movement. That's really good to hear. I'm going to take a listen to your stomach and see if I can hear some bowel sounds. Well, the good news is I can hear bowel sounds. Dr. Hastings also said once you had active bowel sounds that we could start you on something light. Is there anything you care for right now?
Blue Jello.
All right, I'll go get you some.
Thank you.
Hi, Mr. and Mrs. DeLaurentis. I'm happy to hear you're having a good day today. Best news of all, the doctor has put in an order for discharge.
Good. I'm actually feeling really good today.
Good.
No pain really, just a little bit, but when I move certain ways. But
Glad to hear you're in less pain. I do have some discharge teaching for you, though.
The following information is presented on the discharge handout that was passed out to the class. Caring for your T-tube. Do not sleep on the same side as the tube. Secure the tube and bag in place to ensure that it does not get pulled out. Tape a plastic covering over the tube and bandages when you shower. Emptying the bag. Remove the closure from the bottom of the bag. Drain the fluid into a cup with measurements. Record the measurements each time you drain the fluid. Replace the closure of the bottom of the bag. Changing the dressing. Wash your hands, remove the old bandage, and wash your hands again. Use a cotton swab and clean around the incision site and the T-tube. You can use soap and water, normal saline solution, which is salt and water, or hydrogen peroxide. Place a new bandage over the incision and T-tube site, and then tape the bandage in place. With regards to the diet upon discharge, the patient does not usually require a special diet, but is directed to avoid excess fat. Foods low in fat are lean meats, like beef, vegetables, and pasta, but be careful with the condiments. Condiments like butter, sauce, and cheese are what makes the food higher in fat.
So first, the doctor ordered me to send you home an antibiotic, cefamine. You will take 2 pills a day for 10 days. Make sure you take the pills as prescribed to best ensure your infection goes away. You can take them with or without food, but this med is known to cause some GI upset. So you might want to take them with food if you do experience some GI upset. If you feel any type of allergic reaction or think the infection is worsening, like if you notice your incision getting red or more tender, any worse than it is now, it could also have a foul smell, or you could see pus coming from it. Call the doctor and make an appointment. It's really important that you don't skip any of the antibiotic regimen that you're taking, and then continue to drink a lot of fluids to promote bowel functions. The doctor has also prescribed you take something for pain, so we're sending you the hydrocodone acetaminophen. This is to be taken every 6 hours as needed for pain. Pay attention to your incision site and your T-tube until the doctor removes the T-tube at the follow-up visit. If you notice an increase in drainage or the amount of or color, like we had noticed the green color yesterday, call the doctor.
Okay.
Now I'm going to give you a demonstration of how to care for your T-tube and change the dressing at home. So I have some discharge instructions, some general guidelines that I'm going to go over with you, and we're also going to give you one to go home with. So just some general things. Don't sleep on the same side as the tube. Secure the bag to the inside of your clothing. This will prevent the tube from being pulled out. Tape plastic wrap over the bandage and tube site when you shower. For emptying the bag, you're going to remove the closure at the bottom of the bag. Drain the fluid into a measuring cup. Record the amount of fluid each time you empty the bag. You'll share this information with your doctor at the next visit, and replace the closure on the bottom of the bag. For changing your dressing, you're going to want to change the dressing around the tube every day. Wash your hands first, remove the old bandage, wash your hands again, wet a cotton swab and clean around the incision of the tube site. Use normal saline solution or hydrogen peroxide. However, it is also acceptable to clean the incision, the skin around the T-tube with soapy water. After you do that, you're going to put a new bandage on the incision and the tube site. Make the bandage large enough to cover the whole incision area, and then you're going to tape the bandage in place. Alright, so I'm just going to have you sign here for your discharge. Okay. Do you have any other questions for me?
No, I think you made it very clear as to what to do.
Okay.
Thank you.
You're welcome.
Thanks.
Stupid garage doors open. Mr. De Laurentiis, what would you rate your pen?
I can't wait. Ah.
You're supposed to say, won't he need to be on the medication?
Just go. Go. Ow! God. That nurse sucked.
Oh, I'm sorry.
So, cheers.